I thought I had a loud voice. We can measure some of those things, but we do it in silos, and that was something that actually was lacking. Change, we've heard a lot about change, and everyone talks about change. Really, the main thing about change is it has to be developed locally, and it has to be led locally. That's all you can say about that. It's finding the right people, but it's making sure it's fit for purpose where you're doing it. And what works for me, what works in, you know, in Basque country is probably not going to work in Brisbane and might not work in some other situation.
So locally, you mean the group
Yes.
taking
Yes.
the change, not the bits within the group?
No, the group that's doing it, they have to agree what the change is going to be and buy into it, basically. And they have to be committed to it. The key there is trying to align what you want from a system point of view and what you want, what each organisation wants. And some of these are quite tough decisions, conversations, and they don't happen straight away. It happens over time. Commitment to leadership, I mean, that, you know, we've heard a lot about leadership, and that's just pivotal. And we heard a bit yesterday about having a vision. Again, that's something that this quote is one I always use. It's from Scotland. And about having everyone had a piece of the picture, but no one had the picture on the box. And it's having that picture on the box. It's so key. And we think we know, but we don't actually talk about what it is that picture is. And I think that's often why we end up, we have different, you know, parallel trams as with tramlines. Shared clinical priorities. This is actually, from my work, has always been the easier one, because generally you can find out when you get a bunch of people together, whether it's social care, healthcare, funders, whatever, they kind of, that's easy. That's relatively the easy thing to come to grips with, because it is those really complex patients that actually tend to fall more through the gaps. So that has often been the easy one. Incentives to strengthen care. Jerome was going to be here and talk about bundle payments, but unfortunately he's not here. But sharing, it doesn't mean that you have to all cash in your budgets and have one pool. Some people do, that's fantastic, but we don't. It really is about more, there's an alliance contract sort of type of model which Canterbury use, and I think has been used in England, and they're trialling it in places in Australia. It's all about sort of, if we have this big problem, which piece of the pie are you doing? So we're not pooling funds and lobbing them all in, but we're actually agreeing, if this is the problem, this is what I have to do and everyone has to do. So there are different ways of doing it. It doesn't have to be that you all throw everything in. And really it is about trying to look at how we incentivise that joint working. So it, you know, whether you all do a risk sharing, and if there's a benefit that you all, you know, share in that. If you lose, you know, if it costs you, then you might all share in that too. But that's the kind of conversations that you have to have at that sort of regional level. Obviously, a population focus, which I think speaks for itself. Gone are the days where we focused on disease and sort of sections of the population, but looking at what the population needs. Measurement, and this is actually about collecting data across the continuum. You know, hospitals have lots of data, primary care has data, NGOs have data, everyone has data, but we don't have it across the person or the patient's continuum. We do a lot of work with sharing data with our general practices, and it really helps design care, and you start to see where the gaps in care occur. But again, that is very reliant on trust, and people sharing data is, I mean, it has huge improvement, you know, it does help improvement. But you have to actually, it takes a little while to get there, because not everybody wants to give you the data. And that idea of having a collaborative, so when you have an improvement, everybody is part of that improvement for that patient. It's not just the hospital's done the right thing or the general practice or anyone else. It is actually improvement of the system, and you actually celebrate it as a system. Continued professional development. This is about interprofessional and interorganisational education. As one of the CEOs said to me, oh, that's a much lower order thing, we don't do that. Oh God, help me. It's not. If you want culture change, can I tell you, just do that. That's the first step, because if you get everyone in the room and you actually see what everybody else can do. We've done some research that says it doesn't, when we do interdisciplinary education, it's not, we don't learn more about what if it's around complex falls, elderly person or a failure to thrive child, it's not about the clinical content, but what they really learn, what significantly improves is the knowledge about what every member of the team can do. So it's, you know, I mean, it's a no-brainer really in my mind, but it has to be really clear about what people's responsibilities are and actually deciding what they are, because that's where you tend to get some of that tension. Patient engagement, that was the one that was missing from every other review that had been done, which was interesting. And the last one is innovation, and I think this is not just having resources for innovation, but as I said earlier in the session this morning, it's actually about giving permission to innovate. There are many clinicians and people within the health and social care system who know what some of the problems are, but we all get so busy, there's no real way of bringing them together and actually fostering that. They have great ideas. When you say to people something's not working, well, it used to work, we did it like this, and often they have the answers to it. So it's actually providing forums and time for people to allow them to think about what we can do differently. And I really do think that they have a lot of the answers. So the reason those ones were in red, if we go back to the balanced scorecard, was basically those are the two that, in our mind, with our particular aged older person, sorry, am I right? The older person initiative were those two things, and it did actually lead to a little bit of friction, particularly because in Australia we get paid when people come into hospital on activity, and so we were stopping people coming in. The hospitals weren't too happy, going, well, we need them to come in because that's how we get paid. And yeah, but we cause harm when they come in because they're old and frail and vulnerable, so there's a good reason not to bring them in when they don't need to be. Some people obviously need to be in hospital. And it was quite a hurdle to overcome. We did it because we based it on narratives and journeys, and we showed people why, but you will hit them. Like, I'm being honest, this is what we hit. So I'm not going to go through all of these, but the older person thing that we did have some significant outcomes around identifying who our frail patients are, looking at the people that we were, 80% of them we were actually able to discharge from ED rather than have them admitted, which is quite significant. We had a huge increase in using community services, but all the nurses in this team had worked in primary care or from the community, so they understand what is actually, how you need to provide care out there. A lot of the ED nurses are ED nurses. They're about, someone's bleeding and we've got a drug dropping off, let's deal with it, not necessarily managing frailty. So it's actually about having the right people in those jobs. And we reduced hospital admissions. I'm not going to go too much over this, but I think these were sort of some of the key things about these. I used the snakes and ladders theme, so these were the snakes. This is what actually stops things happening. In many cases, those short-term policy cycles, and you have to take that into account. So having the policymakers on board with what you're doing is really important. Hard when they change. And the other thing is that competing driver about, hospitals want to admit them because that's how they get paid. Primary care and community want them admitted because they need access to specialist care. So it's actually about talking about these front and centre and making sure that we understand each other's perspectives, but from a person's point of view, how do we improve care? And we do find that helps probably the most. And the leadership really is pivotal to this. We have leaders across all the organisations who are committed to it, and it took time. This didn't happen overnight. It's taken years, but it actually, you need that level of engagement from both. And when I mean leaders, it's not just the executives, it's the clinicians, it's a whole heap of people. And this is what we need for translation. And again, I think one of the key ones, getting the community involved. Having community voices in there is really important, because even when you hit some of these hurdles, the one thing that you can say, if the community, we've had a group of everyone in the room, all 30 people, and they'll say, well, the reason we can't do it this and this. And when a consumer, in this case a carer, because a lot of our patients are, have a delirium or a dementia or they're cognitively impaired, and when they stand up and say, yes, but from my mum's perspective, this is how you let her down, it's really hard for them to say, well, tough. They actually have to listen to it from a different perspective. Sorry. So I think, we shouldn't underestimate the voice of the consumer. Albert.
Can I just say something in terms of what you're saying? And this has been bothering me throughout this entire conference, and that is that everything you said is right. And the problem is the level at which it occurs.
Yeah.
It occurs at the meta level, it occurs at the policy level, it occurs at the people who are at the management level. Yeah. And the challenge that I'm finding in our situation, where we have a lot of those things already in place, is how you get it down to the really operational level. So, for example, if I want to do integrated care between the community and the hospital, the nurse on the ward, what's in it for her to communicate with the nurse coordinator from the community to do joint discharge planning? What's in it for her? How are we incentivizing those people to communicate with each other and work with each other to give the patient an integrated And the incentives don't go down that far.
Yeah.
In other words, you talk about incentives for the hospital, you talk about it, but the incentives don't go down to the people who have to make it happen.
So what is it that drives people like a nurse on the ward?
So I think,
Care.
for example, if you paid her,
Yeah.
if she got a bonus for doing that, I think that would make a difference. There are other kinds of recognition
also
and
recognition.
incentives. What we need to do is build incentives
Yeah.
that make the people who are,
Yeah.
you know,
So we had that because we merged a whole heap of teams. Some were primary care facing teams. One was an ED nurse, and we had a whole team from the ward. There was nursing, there was a geriatrician, there was a social worker. The social worker ended up going out and working in the community. And then with the nurse on the ward, it was very much like, you know, they'll get them when they get here, and once they've gone, that's not my problem. But when you actually start to do some of these journeys, and when that starts to get fed back, and then you get that person to present to her peers about what the impact has been, it kind of gave her the kudos of, we can make this better. So that's why I'm saying it's a really, truly, I hope, about care in lots of cases, particularly with clinicians, because you don't want to do a bad job, and you do want to make it better. But it's actually about letting them sort of, I guess, be rewarded in the fact that they're trying to do something differently, because there isn't an incentive. You know, well, there is.
Well, they also have to be convinced that they're doing a better job if they coordinate the integration, not only if they do their job well as they've been taught to do it, where they are.
Yeah. But the other thing is sometimes not everybody wants to change, and you have to put people in these positions who want to change. I mean, that's really quite brutal, but we have had places where, you know, they just, I'm doing it my way, I've always done it like this, and you think, okay, well, you carry on doing that, we'll put someone else in and show how you can do the change, because you really need people who understand. The reason we're doing it is not, you know, for our own benefit, we're actually doing it for someone else's benefit. And I think, you know, sometimes we have done that in the past. We've moved someone sideways and put someone else in, because you have to have the right people there.
So, let's see. So, I think I need the next slide. Next slide. So basically, just for the sake of time, I will just try to present you the headlines of our journey at the hospital, and possibly you will recognize some of the points that Caroline has been mentioned before. However, I have to say that as you will see, our journey has not been a straightforward one. So basically, just to give you a little bit of context, I'm coming from Hospital Clinic in Barcelona. That's a university tertiary hospital, something around 800 beds, but this doesn't really matter. What is important to know is that we are a reference center for many really complex treatment, right? Rachel has been there, she knows us very well, and certainly we are what you can say or you can define as a really, you know, high complex technological procedures hospital, something like that. But we also have a dual phase. We are the community hospital for 1/3 of the urban area of Barcelona, and that means something around 540,000 inhabitants. And it is because of that that we had the need to actually start up an integrated care approach in order to cope with some of the issues that at the beginning, and I would like to tell you a story that is as clear as that. I'm going to tell you something that looks like more like that, right? But basically at the beginning was year 2000, so when the foundation started actually. At the beginning we had a pure hospital issue, and that was that during the winter season, all our beds were being used by those COPD patients, basically, or heart failure patients suffering from exacerbations. Our general manager was not happy about that. He called us and said, well, you have to do something about that. You were telling me the other day about different approaches in order to treat in an ambulatory basis these patients. Can we do anything like that? We said, we think that we can do that. So we decided just to look a little bit more on the new theories of Wagner and trying to use those in order to reduce the number of readmissions or the intensity of use of our emergency room department. And basically what we did was design something that was very, very simple at the beginning, was just, you know, at the emergency room, we put together a respiratory medicine specialist and a case manager nurse, right? And they together just undertook this sort of comprehensive assessment. So it was not only about COPD, it was also about everything else, right? And then we provided on spot at the emergency room department this educational program. It was structured, so it was rather quick. We provided accessibility to the case manager nurse, and then we connected with primary care when our work we thought had been ended, and then we could safely transfer that patient back to primary care again, right? So that was really the reason to start everything in our case. So a pure hospital-based problem. Now, for many years, and many years, I mean 6 years, we were operating in really extreme vulnerability, right? So we didn't have that much support from our hospital, from our general manager. Actually, there were many clinicians that thought that we were going in the wrong way, because basically, as Caroline was saying, that meant basically keeping the patients out of the hospital, right? That was the idea. We needed money, and actually we were the ones that actually were seeking for money, thanks to some good European funds that we got, and that was it. But at the end of these 6 years, we managed to be in a position to provide good evidence that was possible, right? And that is what we did. At that point, we were doing just randomized clinical trials, but it was a good experience. In any case, the clinicians accepted that this would work, right? And that was the turning point. So at that point, our CEO decided that we could have our own unit to treat specifically those patients. Of course, this was only COPD, and we were not taking that much into account apart from the main cause, the other comorbidities. So we thought, well, we need to do something with that. We need to escalate that and to make this more comprehensive. So there was another period that lasted 6 years more, and basically this was the period that we used in order to try to better understand how we could manage those patients that were asking, depending on how the condition evolved, different intensity of services, right? And we managed to combine, home hospitalization periods with frailty, or let's say, frailty management periods, and then using also other standard resources from the hospital. That was the overall idea. And this is what actually this graph tries to show. So depending on what sort of intensity of resources needed, then we can apply one service or another. This was going very well indeed, because we were managing also to align to this model of service some sort of financing support from our Department of Health, and that was extremely good, right? And then we also managed to align to a certain extent some new model of governance of these patients, right? So this was very well received and accepted, and we were there. Now the next period was, well, can we transfer what we are doing now to the community? Because absolutely, when these patients are in the exacerbated period, right, then the responsibility must, belong to the hospital, and we are the ones taking care of the home hospitalization program. But once this is done, when we have transferred that patient to the community, I think that it is something that primary care physicians or primary care nurses should be taking the lead on, right? And this is what we tried to do. Now, we tried it at the beginning. It was less successful than what we expected. So we tried to understand why this has happened. And what we realized was that we had done something that was perhaps not properly understood by the primary care physicians and nurses. So basically, we thought that we had already done our best improving and generating the evidence around the goodness of the project, but we had not taken sufficiently into account, the soft, personal issues that were required for them to actually feel committed to the project. And I have to say that because this was perhaps the main barrier. In our case, technology or sharing information was not a barrier at all. We have a full shared medical record, so the clinicians at the hospital or the primary care physicians can see what's going on, not only in our area, but also in other areas. We have full e-prescription, we have all the sources so that we can analyze data and compare doctors and nurses and all these sort of things. So this is all already there. But still, we needed to actually we needed to manage the soft issues related to human resources, and that was mainly the main point, right? this became, or this has become something that is now part of a wider approach in all our urban area, and I have the feeling now that we are entering in a sustainability phase, right? That is the feeling. Now, so my take-home messages are that in our case at least, it took us too long, so we needed to insist all the time that we were on the right track, even if there were many people at the hospital that actually were not convinced at the beginning about that. One of the good points was that there was a very, very strong clinical relationship from the beginning, and this was combining nurses and doctors, a small group, but very committed and you know, pursuing the idea. We did what we could do, taking into account that we needed funding for most of the initiative. So the thing that we did was just, whenever there was funding available, we just tried hard to move in the direction. When funding was not there, then we just stopped it for a while and just wait for better times. That is what we did. So there was a sort of sense of opportunity. We developed along all these years a consistent story. So it was not only about the data, it was also about, well, this means that you as a professional will be rewarded because you will have in front of you a patient that will better understand what you are trying to do, and you will have a patient that will be of greater help to you, so that you will be able to understand better what matters to the patient. That was the story. And yeah, we had to invest, and this was the mistake that we did when we moved to the primary care. We had the need to invest a lot of time and effort in just creating these communities, right? In these communities of practice. So that's true. So perhaps we remain less fragile now, but we still requires effort to keep it. And there were no shortcuts, at least in our case. Hopefully for others it will be easier, but in our case there were no shortcuts at all. So yes, that was all I wanted to tell you about, right? Perhaps perhaps you have recognized some of the points that Caroline was mentioning, but in our case at least was something that we were just developing as we were learning for it. Yeah.
Did you mention the other respiratory units that did not play? Are they still not playing in this? So you had to, there were some doctors and nurses and therapists who were interested and some who weren't.
Right. Exactly. You got it. So even within the respiratory medicine department, you know, there were people perhaps less concerned about COPD and more concerned around other diseases. Yeah, but the point still remains valid, because basically at the end of the day it means that, you know, the clinicians working by you, right, were not in favor of this approach that meant in a way keeping the patients out of the hospital.
Have they changed?
Pardon? They have changed. Not only that. What has been, and this has been one of the learning points also in our experience. At the beginning, being a nurse working in our small unit was seen as something that was terribly wrong, right? Now, once those nurses have become doctors, and they were the first nurses becoming doctors at my hospital, right? Now all the nurses want to come to our unit, right? So there has been a change also in the mentality of nurses, yeah.
And the managers?
Yeah, and the managers now support that. So we started by, you know, back in 2006, they only allocated to us 6 virtual beds. Now we have 38. Yeah. So we are managing 38 patients on these sort of programs, yeah, on a daily basis.
So can I ask everyone here, what would you say, listening to what Albert said of yourself, what would be the key things that you think, from your perspective, in what you have done in Medicare that has really been, you know, the one key thing that has really, any of those things we talked about, or is it something else that's really made it happen for you and how, just to tell the rest of the group? Or what's the one key thing that actually never happened, you know, is the biggest barrier that you just can't get over? So would anyone like to start? Thinking.
So I think, you know, a lot of the things that we talk about in terms of our neighbors, for example, data is important, but when you said you're passing along stuff like that, that's fine. Well, you know, I know places where they're still sending each other faxes.
It still works.
It still works. The thing is the will to share the information. That's not the technological way to show the information. So the question is, how do you generate the will? and how do you generate flow. Now you have some people who are visionaries or who are intuitively focused that way and try to push it forward. But you know, we all are experiencing shortage, for example, of nurses, and nurses are very key, in my mind, to the whole integration process,
Absolutely.
both in the community and in the hospital. And I think we need to rethink somehow, as I watch this play out in the field, we really need to rethink from in a very innovative way how we build the incentive systems. And part of our problem is that we have unions, right? And we have all kinds of other administrative regulations and all kinds of administrative barriers that say, no, you can't do that. This is how you have to pay people. And you can't change that without, you know, sort of an act of God. But we really need to, I think, rethink that whole structure so that we have everybody kind of, so that we are incentivizing them in a variety of ways to go in the direction of integrated care.
I think the will. Sorry, yes. Sorry.
Well, I might just follow up on that. I'm from Germany, so I think we have a very different situation at the moment because no social care system in place in some kind of unique organizational form. But what I was thinking when I heard both of you is who is the owner of the process, and that's also, you were saying we have to think through and do it in a different way. So the question is always who is we and how do we get the people to move in the end. So what I really liked about your presentation was, and that gives me hope for our situation a little bit, that if you have some people who are committed in a clinical setting, you can start out with that and then still achieve a change, even if the system is not maybe ready for it at the beginning.
Right. I think that at least in our case, it worked that well, right? And I would say that I think that we have seen that happening also in some other places all over Europe, right? So yeah, I think it's a good start, right? Yeah.
For me, I think it's the shared vision. I think in Australia we've experienced talking about the patient-centred medical home over the last few years, and it's filtered right through to a number of, everyone talks about it now. So we're getting towards some sort of shared idea of how it might look, and you need that vision to know where you're going to incentivize people towards.
Yeah.
I still don't think we're quite there, but
it starts that conversation.
Yeah.
You start looking at it as a whole rather than.
yeah. Otherwise, you've got your organisational mission or your own particular professional sector's mission, and you don't have this shared idea of where you're all heading. So I think we're still at that level. I don't know what you guys, other Australians, think, but I think we don't really have that vision yet.
Yeah, I think in Australia we're organised around the wrong things still. We're organised around money, we're organised around power, we're organised around, and perhaps that's the way the world works. But therefore, to organise around integrated care, you have to find an entirely different plane of thought. Things that seem to me to work are, first of all, there are very, very few clinicians and managers and accountants who are not moved by and excited by a demonstrated benefit to a patient. There are very few, especially to a group of patients. And part of the narrative is to make that visible and credible. And when you do that, it's amazing what you can achieve. The next thing, I think, is respect for the people who do the work, which includes the patients and their families, but also the nurses, the allied health professionals, and to some extent, for example, not all the doctors are high-grade consultant level people. But to me, if the work is respected and meaningful and demonstrably valued and reflects the values of the people there, you've really created the conditions. Then it's just a matter of chipping away with the narratives. Is that too abstract?
No, I think along with the narratives comes the data. Because what you were saying,
true narrative.
True narrative, because I think what you were saying about how to get people like the nurse in the hospital or a practice or wherever to buy in. We've got working together agreements with a lot of practices who share data around various populations. But the practices are fantastic, the general practices. It's de-identified and it's secure and we don't use it for anything. We've agreed to all sorts of things, but when we share that back to the practices to say, this is the journeys of your patients, not just your practice data, but the hospital data. And you start, then intuitively, whether it's the admin person or the nurse or the doctor, they'll start saying, why does that happen? And you can't help them, but they're already jumping 3 steps ahead. You go, hang on a second. So the data is really powerful if you can look at it from a continuum perspective, not just from one bit of it. And we've had nurses who say, I don't do data, I just want to do clinical work. And 3 years later, they're going, I haven't got time for this because the data is, everything I felt in my gut is the data tells me it's real. And they get really passionate about it, and they were never going to be researchers, but they just fall into it because it validates what you actually know and feel. So I think the data is really, really important. What is one thing, I'm just conscious of time, what is one thing you would say that doesn't work? What's something that you've come across that's just like stops it dead in its tracks? Don't say funding.
Well, we're changing policies and leaders. So in some ways, you don't want a completely stable system because you want innovation and creativity, but there's continual churn of managers and leaders, and so you don't have people there long enough to actually make sure it continues. And then living in a democracy, you have changes of government and changes of policies, and particularly if you're in a federal system. So we've got at a federal government level projects about looking at healthcare homes, which are not quite patient-centred medical homes, an announcement on Tuesday night in the Australian government budget about a payment to general practice for chronic patients, for practices to enrol chronic patients. And at a state level, we've got value-based care in New South Wales, we've got other sort of things happening, Agency for Clinical Innovation. Then we've got the aged care system has been turned on its head in the last 3 years, now the National Disability Insurance Scheme. And so how do you develop integrated care in a way that it will actually bounce off those things and actually use them to make integrated care better, as distinct from it stops it or people have to start it again. And nurses in Australia are actually quite expensive. So if you want an experienced clinical nurse, you're paying something like 60,000 euros or 50,000 pounds. In Australian dollars, 100,000 plus with on costs. They're actually quite expensive.
I know we've got 1 minute, and I know that something's going to take off in a minute if we don't get off the stage. What's the one key home? What would be the one thing that you take away from today?
It can work, and it does work, but you have to apply it in a way that's going to fit your context and setting.
And be flexible.
And I think also it works at multiple scales.
Yes.
So if you can't do it because the geopolitics are getting in the way, then perhaps you can do something in the street you live. I think so. It's scalable and it works.
And I think, like Albert showed, you start small with just one idea, and you're just persistent. You just don't give up. You know it, you believe it, and you engage the right people. Which
It also helps somebody.
It tells a good news story, and everyone generally likes that. Have you got any other comments from other countries?
I think one thing that's interesting that's come through in a lot of the talks is having the patient story and the patient persona, whether it's the real patient or whether it's a fictionalized patient that has gone through. Because I think any patient that's gone through a system where good integrated care has been delivered and been experienced, they're our best advocates. So I think the patient movement is one that we really have to embrace.
And also, to some extent, certainly in Australia, is integrated care is seen as a health issue, when it should actually be a national issue, because it's not just improving the health of a person, it's improving social stability, it's something that's actually that business should be interested in, and all ministers should be interested in, not just the health minister. And we've allowed it to just be a health issue, and the rest of society and the economy ignores it.
Thank you all very much. Thank you, Albert. I'm sorry for the flexible way in which we had to do this.
Thank you, Betty.